Post-traumatic stress disorder in older adults is a really significant public health challenge, but one that's been critically under-researched. So today, we're going to dive into a major review from the Lancet Healthy Longevity. It synthesizes a whopping 142 different publications to map out a clear research agenda for the future. Let's get into what they found.
You know, we're standing at the intersection of two huge global trends. First, we're all living longer. And second, over 70% of people are exposed to a potentially traumatic event at some point in their lives. This creates what the paper calls a clinical gap. See, even with this massive demographic shift, PTSD in adults over 60 is a major and often overlooked burden. We're talking about chronic symptoms that can last for decades, relapses that get triggered by late life events, or even cases where the onset is delayed by years after the original trauma. So to really get their arms around this complex problem, the authors conducted a very robust systematic review. They analyzed 142 peer-reviewed articles, and they structured their whole analysis around 4 key clinical pillars: the biological aging mechanisms, the methods of clinical assessment, the effectiveness of treatment, and the existing care models. This framework really gives us a comprehensive map of what we know, and maybe more importantly, what we don't. All right, so now we're going to walk through the core findings from each one of those 4 pillars. And I'll tell you, the evidence really paints a concerning picture of just how little we understand. Okay, the first pillar reveals this deep, profound link between PTSD and the actual biology of aging. We're seeing solid evidence for what's called accelerated biological aging. I mean, some studies have linked PTSD to epigenetic clocks that show an accelerated aging rate of about 4 months for every single year in veterans. We're also seeing shorter telomeres, which is a sign of cellular aging, a high prevalence of metabolic syndrome, and really clear evidence of immune dysregulation, a state of chronic inflammation that's sometimes called inflammaging. Now, shifting from the body to the brain, the research confirms something pretty stark. PTSD is a significant risk factor for dementia. This is backed up by evidence of structural changes in the brain, like atrophy in the hippocampus. And what's really crucial here is that severe PTSD symptoms are linked over time to the buildup of amyloid and tau proteins. And of course, those are the core pathologies we see in Alzheimer's disease. On top of that, you have reduced functional connectivity in key brain networks and real, measurable declines in things like executive function and attention. So given this really clear biological impact, you have to ask, how good are we at actually diagnosing PTSD in this population? Well, the findings from Domain 2 show we have a major assessment gap. Older adults often show up with more physical and cognitive symptoms and less of the classic avoidance behaviors, which means they get underdiagnosed. And our gold standard diagnostic tools, they've mostly been validated on male veterans, not on civilians or women. This creates a massive blind spot. And get this, there are 0 validated screening tools for older adults who also have dementia. None.
Which brings us to treatment, and honestly, the findings here are deeply concerning. When it comes to psychotherapy, the evidence we have is based on just 10 small, randomized controlled trials, which makes the quality of that evidence pretty low. But for pharmacotherapy, for medication, the situation is even more dire. There are 0, not a single one, randomized controlled trials looking at the safety or effectiveness of any medication for PTSD specifically in older adults. That is a critical, gaping hole in our knowledge that directly impacts patient safety.
And finally, let's look at the care environment itself. We hear a lot about trauma-informed care, or TIC, but what this review found is that it's empirically scarce in aged care. Think about it. Standard routines like locked wards or even just intrusive personal care can inadvertently act as triggers and actually re-traumatize a patient. And this vulnerability is just magnified in patients with cognitive impairment because they have a much harder time regulating their emotional responses. So, now that we've gone over the findings and seen the gaps, let's turn to how the paper proposes we move forward and start to address all this. I mean, just look at this. This visualization tells you almost everything you need to know about one of the biggest problems. The overwhelming majority of the research has been done on male military veterans. There's a severe lack of data on women, on civilians, on the oldest old, that's people over 75, and on individuals in low to middle income countries. This huge sample bias severely limits how much we can apply any of the current findings to the general aging population. So what's the fix? Well, the authors propose a really clear 4-step research agenda. First, ensure inclusivity by actively recruiting diverse populations. Second, standardize the methodology, using modern diagnostic criteria so we can actually compare results across different studies. Third,
Measure functional outcomes that actually matter to patients, things like quality of life and social integration. And fourth, and this one is so important, mandate the co-design of studies with survivors who have lived experience to make sure the research is relevant and actually applicable to real life.
So what does all this mean for practitioners on the round? The paper boils it down to 4 key implications. First, actively screen for physical comorbidities, like cardiovascular disease in any patient with a history of trauma. Second, stay vigilant for delayed onset PTSD, especially after big life transitions like retirement or bereavement. Third, apply trauma-informed principles in long-term care settings. And finally, exercise extreme caution with polypharmacy, always remembering that no medication has actually been tested for this specific group in a proper clinical trial. All right, let's just summarize the 3 absolute most critical take-home messages from this paper. First, PTSD in older adults isn't just a mental health issue, it actively drives accelerated biological aging and increases dementia risk. Second, our current evidence base is dangerously skewed towards veterans, and we desperately need inclusive, civilian-focused research. And finally, effective geriatric care absolutely requires integrating trauma awareness into standard practice to stop the cycle of re-traumatization.
You know, this research really forces us to confront a fundamental question with enormous implications. This isn't just about mental health. It's about the very biology of how our bodies age. So the question we're left with is this: how must our public health strategies evolve to address the profound link between trauma and the biological processes of aging? And you have to wonder, what other hidden connections between our minds and our bodies are we still missing?